Good morning, everyone. So, talking about clinical assessment, so I will really try to go back to basics. And some of the information that I'm giving you here, you can find also on this paper, which is now 4 years old, which we did with the European Society of Intensive Care Medicine. So, why is the clinical examination important? Because actually, understanding if a patient is in shock is not something that we are going to get from any device or from any test. It really comes down to our clinical skills. Yes, there is a little bit of extra that we can do, and I will show you, but it's very basic. We are talking about measuring a lactate, and I think probably nowadays we're also talking about maybe using a bit of basic ultrasound, so basic echocardiography. But we need to go back to understand really what is shock. And circulatory shock is a life-threatening, generalized form of acute circulatory failure associated with inadequate oxygen utilization by the cells. So what does it mean? It means that we have a failure to deliver, to transport some oxygen, and at the same time the cells are not compensating anymore, and it means that they are not able to extract the oxygen for their needs in the right way. When I go and see patients in the wards or when I see patients in my intensive care unit, I always like to think about how the human body is trying to compensate. And if you think about the homeostasis of the way we react to crisis continuously, I like to think about the respiratory system, the cardiovascular system, and they are really instantaneous feedback servo mechanisms for which they work continuously. If I stand up, my baroreceptors will send a signal to squeeze the veins and the arteries in my body so that my blood pressure doesn't drop. On the other hand, if I change position, this will change again. And this is something that happens continuously. So the cardiac output, the venous return, the will try to compensate very, very fast according to the metabolic needs of the patient. And at the same time, the respiratory system is doing the same. So the metabolic needs that may increase some of the carbon dioxide production, this will drive an increase in the respiratory rate. And again, these two things that will try to work continuously to try to maintain a normal pH, to try to maintain some sort of balance between delivering of oxygen and also carbon dioxide clearance. I put that the renal system, because the renal system is also working continuously, sometimes the effect of what we are able to see, which is basically urine output, may not be apparent as something that happens second by second and minute by minute, but actually kidneys are working for that too. A kidney that stops passing urine in a moment in which there is bleeding is not a kidney that is failing. It's a kidney that is bringing success to what it's supposed to do, is retaining some volume in the system. So it's a bit more difficult to understand that in the concept of an instantaneous mechanism, but it is something that it is there. And what is our windows to what we are seeing on this? What our windows is really our clinical examination. And it goes back to touching our patients, so getting a feeling of the temperature, of looking at the skin, looking at the heart rate, looking at what happens in terms of blood pressure. And I will show you how even simple analysis of blood pressure that we can get just from looking at the systolic and diastolic blood pressure can give us some very important information. Of course, the mental state of our patient, the respiratory rate, is a very, very important parameter. And as I say, the urine output. As you see here, there is nothing about devices. It's all about examining our patient. And even if, as I said before, if we measure in the blood lactate levels, and lactate is not just happening because we don't have enough oxygen delivery, it can also be done to inflammatory mechanisms. But in the initial phases of shock, the mechanism of the inadequate oxygen delivery and oxygen extraction is certainly very important. So I also like to have this formula in my mind when I think about how I can help my patients to compensate for that. If I look at the oxygen delivery and I have my cardiac output here multiplied by the oxygen content in the blood, what am I left in terms of things that I can really manipulate? Well, the oxygen content in the blood will depend on the total amount of hemoglobin that I have, on the saturation of this hemoglobin, of course on the amount of millimoles of oxygen that are linked on average to these millimoles of hemoglobin. And then there will be some part of oxygen that is directly dissolved in the blood. As you see, the amount that is here is multiplied by 0.003 in terms of this by the tension of oxygen. So the truth is that unless I have a patient that is incredibly anemic, bringing a high FiO2 to increase the PO2 is probably not a good strategy. And actually, we have some evidence that bringing tissue hyperoxia to patients in intensive care can be detrimental. So I'm going to take this away from my way of thinking on how I can compensate. And I'm left really with hemoglobin. But hemoglobin is something in which we can prevent severe anemia. When we give blood, unfortunately, we are not just bringing a carrier, we're bringing blood that has been processed, that has sorts of side effects, and etc. And we know that we cannot overtransfuse our patients. So I can prevent trouble there, but I cannot really make much of an impact. And for oxygen saturation is the same. It goes from 0 to 100%, but in a state of normality, I will be normally running on a saturation above 92, 94%. So I cannot gain much just by giving oxygen. Even if I get 100%, well, it's not really a big deal compared to where I want to go. So the truth, as you understand here, as long as I try to minimize damage on the oxygen content side of things, the only variables that can be regulated to match the oxygen delivery is cardiac output. And that's why we like hemodynamic monitoring, and that's why we like to think how we can balance the oxygen demand and the oxygen delivery. So often when we looked at cardiac output, we think about stroke volume and heart rate, and preload is really where you will get 90% of the talks, the critical care conferences, or where our thinking is. But remember that contractility and afterload are equally important, and sometimes they're sort of forgotten variables in this. They're still equally important into the relationship of bringing the cardiac output to an adequate level. So just to remind you, what is the problem locally when I have an area of my microcirculation that is shunted or is not receiving enough oxygen? What happens is that my glycolysis will be normally in a state of aerobic metabolism, bringing a very efficient production of ATP. And actually, if locally I have a shunted circulation or a circulation that is now working or start to work in an anaerobic way, the production will be much less efficient. Lactate, remember, is not the problem. Lactate in this moment is the fast solution for our cells to receive some energy. But the high lactate is telling me that at the microcirculation level, what's happening is that I'm not efficient anymore. I start to be less efficient, and in order to survive, I am producing a lot of lactate. This is what happens if I run a marathon. Athletes that win marathons, if you measure the lactate level, they will be very high at the end, and they're able to work with that. It's not that they are in shock. They are producing both aerobic metabolism, but there will be some sort of degree also of anaerobic metabolism there. Nevertheless, a production of lactate in a shock state is telling me that some of the pathways, they started to shift towards dysoxia, towards a less efficient way of producing energy. As you see here, when I become less efficient, I'm producing also more carbon dioxide in the system, and I will show you how we can use this, and also more hydrogen. So what would the system do if I am in this situation? We will probably try to increase the cardiac output to try to bring more oxygen to the cells, and at the same time to try to clear some of the carbon dioxide. My respiratory rate will go up, and at the same time I will try to find mechanisms also with the kidney to trying to bring the pH to a normal level. Again, what is my window to understand all of this? Going back to my clinical examination and try to understand if the heart rate changes, if the changes they see in all of these clinical windows are related to any of this. No matter how you look at it, lactate levels that are high, while there may be a fast solution for the organism in that moment, for the human body in that moment, they are associated with worse outcomes. Because the reason that I am producing lactate means that there is a problem to start with. And this is a very old slide from one of the fathers of our specialty, in which is really showing that even small amounts of lactate production are associated with drop in survival in critically ill patients. Hypotension, a hypotension that is a de novo hypotension, should always be considered a medical emergency. As I was saying to you before, our baroreceptors are usually pretty good in maintaining a good mean arterial pressure, And actually, the mean arterial pressure is one of the most regulated variables in our body. We've been having evolved as mammals through the evolution to try to protect perfusion pressure at all costs. So when perfusion pressure drops, usually there is a problem. As we talked about it in the previous days, if after a few days in intensive care, a patient can auto-regulate on a lower level of blood pressure, that's something we can think of. But when we're taking a new patient in the emergency department, a patient that we didn't know that was hypotensive or running on low blood pressure before, then a hypotensive should always be considered a medical emergency. And even small episodes, short episodes of hypotension that resolved, they're associated with in-hospital mortality. As you've seen in my talks, I really like to show these slides very often because I think it put the pictures in perspective. Often I've been asked whether it's more important the perfusion or lactate levels or hypotension or blood pressure. I don't think we can answer that question. They are both equally important. I want to have good peripheral perfusion and I want to have a good perfusion pressure for my patients. And as you see, there is really a synergy here. If I have a patient that has a good systolic and a low lactate level, this patient will have a low mortality, so I would argue probably these patients are not even in shock. But even for a patient with a good systolic blood pressure, when the lactate levels start to increase, I will start to see a significant increase in the mortality of these patients. Equally, patients that have a low blood pressure, even with what is considered to be a normal or a low lactate level, well, the vasoplegic state, when it's very severe, it's associated with organ dysfunction and with death. And the sickest patients, and these are definitely patients that are in shock, are the ones that have a severe vasoplegia associated with severe hypoperfusion. These are very, very sick patients. I think we don't have to be very clever here about thinking whether we can wait a bit or not. These are patients that we should monitor very, very carefully. So what are the clinical windows in practice? Well, the skin, often forgotten because it's very easy and simple to look at a monitor in our patients. But actually, if I go and see the skin mottling is a very powerful sign of shock. You can even score the mottling now. And patients that don't resolve their mottling early, they're associated again with worse outcomes. And when I looked at the skin and the peripheral perfusion, I can do very simple tests like the capillary refill time or measure the temperature, the difference between the toes and the central temperature. And again, maybe there is not a lot of research there because devices are not marketed to measure this temperature on the skin, but the data is very consistent. If I have patients with a very cool periphery, if they have patients with an increased capillary refill time, these are patients that usually didn't do very well. So for instance, this study by Kaplan of many years ago now was showing that if I simply classify patients between having a cool periphery or a warm skin, well, I can see very significant difference if then you go and measure their cardiac index, their pH, their SCVO2, and their lactate. And patients that are not able to normalize the capillary refill time after some interventions are much more likely to have either a dysfunction, a more severe organ dysfunction, or to have a much higher lactate level. So what I say to all of my trainees or my staff is always, tell me what's the value of the capillary refill time. I really want to know, is the patient warm or if the patient is cold? And that's the first thing that usually I do when I go and see a patient at the bedside. I really want to try to touch what's going on there. So if we identify that the patient is in shock, we then have to try to understand why that patient is in shock. And again, this is one of the major contributions of Harry Weil, was really the classification of shock. I'm not going to spend too much time into this, but clearly it's not just realizing that the patient is in shock, it's trying to understand also what is the cause so that we will be able to treat it as early as possible. An evolution of this classification or using this clinical examination to understand this classification, especially nowadays that we've realized that it's very difficult to separate one shock from the other, and very often we will have, for instance, a cardiac component in a septic shock, or we may have patients that come with a cardiogenic shock that will evolve in a post-cardiac arrest syndrome, which is very, very similar to a distributive shock like in a septic shock. This classification you can find also in this nice review by Jean-Louis Vincent and Daniel De Backer, in which again is explaining everything that I told you now. and he put, as you see here, arterial hypotension as the trigger to think that something is happening, because often that's the reason why we are called to see patients in the wards or in the emergency department. And again, then we have to look at all the signs of hypoperfusion. Let's not label a patient as just a bit confused or a bit mad. A mental state alteration should be something that should warn us about something that is happening. Let's look at the skin. Let's try to understand what's happening with the kidneys. And let's look at tachycardia. Let's see what's happening in sense of blood pressure. If we can, let's measure a lactate level very fast. It's not very expensive now in the majority of the countries where we work. What we put here is also echocardiography. Echocardiography is not part, of course, of the initial clinical examination, but I think if a patient is sick enough to come under our care and therefore to come in our intensive care units, probably nowadays the availability of echocardiography should prompt us to do a basic echo examination, because just by looking very simply, very simple views, not views for which you need to be an expert, you can start to understand maybe what is the main reason of the shock in this patient. I'm going to conclude just showing also some simple things that we can do by looking at the arterial blood pressure. If you remember from the studies of Otto Frank and Erlanger in the previous centuries, we know that the pulse pressure is proportional to the stroke volume. So if I look at the relationship between systolic arterial pressure and diastolic pressure, and of course that will give me also the mean arterial pressure, I can start to understand a bit better maybe what is the perfusion pressure of my patient, and also what happened in terms of changes of cardiac output and stroke volume simply by seeing the relationship between the two. Just to remind you, the mean arterial pressure is the average pressure over time, which is basically what would be if I would be perfusing not in a pulsatile way all of my organs. And it's very important because it's related to the perfusion of our patients. Let's remember that according to the site where I'm measuring my blood pressure, we record different values of systolic and diastolic blood pressure. I often laugh a little bit when a surgeon asks me to keep the systolic blood pressure around 120, because if I measure it at a radial level or at a femoral level, it's normal that those two levels will be different. There's nothing wrong about the measurements. It's the right thing that the pulse wave of augmentation will make the systolic going higher and the diastolic going lower, further I go from my proximal aorta. What does it mean though? It means that usually my mean arterial pressure will be preserved, but the relationship between the systolic and diastolic may be different according to the side where I'm looking at. Mean arterial pressure should not be seen just as an absolute value. If I have a patient in shock, often I will have a central line. And again, very simply by looking also the central venous pressure, so the right atrial pressure, you have to remember that the real perfusion that we have in our organs depends on the mean arterial pressure minus the right atrial pressure. If I look at this, I can also transform this into the relationship between my perfusion pressure, which is equal to the cardiac output times the systemic vascular resistance. This is one of the reasons why I don't like to look at systemic vascular resistance. It doesn't tell me much. It's a number that comes from too many numbers together. I'm more interested in the split of these three variables so that I can understand where I can intervene. If it is a problem of the mean arterial pressure, I will have to act in one way. If the problem is the right arterial pressure, I may have to act in another way. And if the problem is the cardiac output, I will have to act in another way. Just looking at this makes me blind to all the other three. Just to give a clinical example of how much information we can get from this, if I have a patient that was staying at home and was living quite happily, but then something happens. And for instance, let's simulate that that patient had a trauma, a car accident, and now is bleeding. The normal reaction would be, as we know, that by bleeding we are decreasing the stress volume, so therefore the oxygen delivery will start to become inadequate. What will be the compensatory mechanism of the system? Well, the heart will try to become more efficient by trying to decrease the central venous pressure and to facilitate the venous return. I will have tachycardia. The stroke volume probably will become smaller. And how would I be able to see that on my pulse pressure? Where probably, and it's not just probably, that's what happens, the pulse pressure will become smaller. Now, if I have tachycardia, then the diastolic time will also become shorter. And that means that my aortic recoil will not be able to give enough time for my diastolic blood pressure to go very low. So if I have a patient that is bleeding and there is sufficient vasoconstriction, what I will see is that there is a drop in the pulse pressure, but the vasoconstriction and the shorter diastolic time will probably increase the diastolic blood pressure. An example of this are young patients with very good vasomotor tone that are bleeding. If we just focus on the mean arterial pressure, we may take this very wrongly. If I look at the perfusion, this is a patient that may require very fast fluid administration. Opposite situation in terms of vasomotor tone, if I have a patient that is now vasodilating or becoming septic, well, in this case, still the compensatory mechanism will be a tachycardic effect. If the cardiac output is dropping and the venous return is dropped because of a redistribution of my stress volume, again, the pulse pressure will be smaller. The shorter diastolic time should still tell me that the diastolic blood pressure should stay up. So if I see a patient with a very low diastolic blood pressure and tachycardia, as we always say with Jean-Louis, that's a patient that is very, very sick. That's a patient in which the vasodilatory mechanism is so important that I'm not able to get that blood pressure up just by giving fluids. That may increase my pulse pressure and my stroke volume, but it will not be enough to raise my mean arterial pressure. So just to conclude, I think the nice thing about what we do in intensive care is really often focusing on clinical signs, and we need to go back to clinical examination to understand that the patient is in shock. I do believe that echocardiography is becoming at least a basic level like the stethoscope of 30, 40 years ago, so I'm going to put it there as an adjunct to our clinical examination, and the only extra thing that we need to do to confirm how sick the patient is to measure a blood clot level. So this is all clinical, and I really think we need to go back to basics to make sure we don't miss this patient. So the recognition of shock is still a clinical skill. It is mainly really via clinical physical examination. Let's not miss the important windows, the mental state, the skin, the urine output. Have a look at the blood pressure, and just, if you can, also try to bring some basic echocardiography to your units. Thank you.